Okay, let's talk about nephrotic syndrome. Nephrotic syndrome, O for nephrotic, so you have massive proteinuria. And what is the level? Greater than 3.5. That's great that they have mentioned that. And let's talk about it now. So first of all, we have the minimal change disease. And minimal change disease, also called lipoid nephrosis, often primary idiopathic, triggered by recent infection, immunization, immune stimulus. So 4 I's could be idiopathic infection, immunization, immune stimulus. Rarely secondary to lymphoma, with example, cytokine mediated damage, and this leads to loss of antithrombin 3, leads to renal vein thrombosis. Light microscopy will show normal glomeruli, very important. Normal glomeruli, but with renal vein thrombosis or loss of antithrombin 3, that's the minimal change disease. Lipid may be seen in patient in PT cells. Okay. Then we have immunofluorescence. Because it's a normal glomeruli, we have negative immunofluorescence. So no immune complex depositions. That's what we mean by immune fluorescence. Electron microscopy shows effacement of the podocyte foot processes. Look in picture A. You have effacement. So you have effacement of the podocyte foot processes here. Okay. Instead of nicely, you don't have that. There's an effacement of these foot processes. So now let's also talk about some important points out of this thing. So which infections are we talking about? We're talking about any upper respiratory tract infection. For the drugs, we also have to mention the drugs. Drugs can cause it, like NSAIDs can cause it. And which lymphoma? Hodgkin's lymphoma. Okay. Now, for the pathogenesis of this thing, although we talked about all the triggers and everything, but what is the pathogenesis? Why is it happening? It's a T-cell mediated injury to the podocytes. So T cell cause damage to these podocytes, leading to effacement of these podocytes. Which, when you efface these podocytes, you're losing the negative charge. When you lose your negative charge, the proteins which are negatively charged will be lost in urine. For example, albumin is going to go in urine, antithrombin 3 is going to go in urine. Okay, so it's in here you have selective proteinuria, because all you're losing is negatively charged proteins. Okay, so that's what we have with the minimal chain disease. And remember, it's a T-cell mediated damage, and these are the initiators that stimulate T cells, and it causes damage to the podocytes. Alright, moving on, what do we have? Then we have the focal. Focal means only 1/3 of the glomeruli. Segmental, only segment of the glomeruli. Glomerular sclerosis. Okay. So when we say focal, and we did this nomenclature beforehand, we're talking about less than 50% of the glomeruli, or the segment of the glomeruli. So it can be idiopathic, primary or secondary due to HIV infection, sickle cell disease, heroin use, obesity, INF treatment, or congenital malformation. I mean, you can memorize all of this. It's really hard. So just keep in mind pathogenesis, and that's going to help you out with it. So let's talk about that. May progress to CKD, chronic kidney failure disease, may more common in black people. You are in light microscopy, you're looking at segmental, because we talked about segment, sclerosis, because we talked about sclerosis, and hyalinosis, right? Looking at picture B, you can see segmental. Only segment has been there's sclerosis only in the segment of it, right? So that's that is what we have in this thing. So when we talk about immunofluorescence, again, it's negative. We don't have any immune complex deposition. It's negative, but maybe positive for non-specific focal deposition of IgM, C3, and C1s. So although more commonly it's negative, but could be positive for all these things. And then you have the effacement. Again, the same issue here. Effacement of the podocyte foot processes. Okay, again, same thing, causing albuminuria, antithrombin 3 to go out. But this is focal segmental. Less than 50% of the glomeruli has gone into sclerosis due to the fact that you have a primary idiopathic or secondary infection-related problem. Black people with can lead to CKD coming with the focal segmental glomerulonephrosis. So that's pretty much all we have for this thing. Let's move on with membranous nephropathy. Membranous nephropathy, also called membranous glomerulonephritis, can be primary due to antibodies to phospholipase A2 receptor, or secondary to drugs like NSAID, penicillamine, gold, infections, or HPV, HCV, syphilis, SLE, or solid tumors. Increased risk of thromboembolism like DVT, renal vein thrombosis. Okay, so you have on light microscopy you will see it says membranous nephropathy. So diffuse capillary and GBM, glomerular basement membrane thickening. Look in picture C. So here we had sclerosis of only a segment. Here we have diffusely membranous nephropathy, membranes, diffuse membranous, diffuse capillary and glomerular basement membrane thickening. Okay, on IF you will have granular due to immune complex deposition. You will have a spike and dome appearance of the subepithelial deposits. So spike and dome appearance with these subepithelial deposits. So think about it this way: you have the podocytes, right? So podocytes are the epithelial cells. So you have deposits under them. You have the basement membrane, you have the endothelial cells, and now this is the blood, right? So when you deposit these immune complexes, you will have a spike and dome appearance. Where does it go? So where deposited goes there, spike, and then dome, spike, dome appearance. Okay, that's the membranous nephropathy. Okay. And now the question is, what is going to correlate with the disease activity? What is going to correlate with disease activity? That is your anti-PLA2R antibody titers. This anti-PLA2R antibody titers is going to correlate with disease activity. Now this, one last thing actually. On electron microscopy, you see spike and dome appearance of subepithelial deposits, right? So the question is, how do you see that? Well, you can see that if you were to do a silver stain or pass stain, which is periodic acid skiff staining. Okay, but yeah, that's all what we have for the membranous nephropathy. Then we're looking at amyloidosis. This is kidney's most commonly involved organ. Kidney is the most common organ for the amyloidosis, associated with chronic conditions that predispose to amyloid depositions. For example, AL amyloid and AA amyloid. Prolonged dialysis is the other cause. You have the Congo red stain, which shows apple green birefringes under polarized light due to amyloid deposition in the mesangium. So what is the Congo red going to show you? Apple green birefringes under polarized light. Deposition where? In the mesangium. AL amyloid may be positive for lambda and kappa light chains. AA amyloid positive for AA protein. Mesangial expansion by amyloid fibrils. Okay, so that's pretty much all we have for the amyloid. Let's talk about a very important topic, which is called diabetic glomerulonephropathy. It's most common cause of end-stage renal disease. In the United States, hypercalcemia causes non-enzymatic glycation of tissue protein, leading to mesangial expansion, which, when the mesangium expands, causes glomerular basement membrane thickening, which causes increase in permeability, hyperfiltration, glomerular hypertension, and increases GFR, leads to glomerular hypertrophy and glomerular scarring, glomerulosclerosis. Further, a progression of nephropathy. What do we look for? Look for albuminuria with increase in urine albumin to creatinine ratio. ACE inhibitors and ARBs are renoprotective. So in diabetics, if you were to give an ACE inhibitors or ARBs, they are going to protect that patient from developing ESDR because these are renoprotective. Let's talk about the light microscopy will show mesangial expansion, glomerular basement membrane thickening, eosinophilic nodular glomerulosclerosis, which is very important, called Kimmel-Steele-Wilson lesions. Looking at picture D, you have these Kimmel-Steele lesions. Okay, looking at, let me show you here. Kimmel-Steele, look. Okay, on your immunofluorescence, there are non-specific staining, usually negative. Immunofluorescence is negative because it's not the antibodies or complement that is depositing, but here the pathology is the non-enzymatic glycosylation. So glucose, it's so much glucose in the blood that they undergo non-enzymatic glycosylation, and they deposit that into the mesangium, leading to thickening of the glomerular basement membrane, leading to that would cause an increase in GFR. When you thicken, you increase permeability, leading to hyperfiltration, glomerular hypertension, and increase in GFR. And that when you increase GFR, you're causing hypertrophy, and eventually scarring can occur, which is called glomerulosclerosis, and it can progress to ESDR. But you can prevent that by giving ACE inhibitors or ARBs to diabetic patients. Okay, so on your electron microscopy, you will have prominent thickening of the glomerular basement membrane with expanded mesangium, predominantly due to increased mesangial matrix and segmental podocyte effacement. With all of this in mind, let me now talk about some important points of this thing. So some important points are, so you have a moderately increase in albuminuria, which is about 30 to 300. Now this is called microalbuminuria. And this microalbuminuria is the earliest manifestation of diabetic glomerulonephropathy. Okay, but once the albuminuria gets greater than 300, at that point it can be detected by urine analysis. So urine analysis does not detect any proteinuria which is less than 300. So if you want to get the earliest sign of diabetic glomerulonephropathy, and you are saying to the patient, hey, give the urine, we're going to go for urine analysis, check your urine protein levels. I mean, it's not even going to check. It's going to check when you have a full-blown disease, right? You could prevent that from happening by stopping it here at 30 to 300 level, but you were like, man. So, okay, that's the one thing to keep in mind. But that's a very important point. Other than that, now let's talk about screening. How do we screen for diabetic nephropathy, right? It is done by albumin-specific urine assay. So what is the thing you got to do? Albumin-specific urine assay. Okay, this is going to check the levels. Also, for diabetic nephropathy, also screen these patients for diabetic retinopathies. Okay, so these are the two things that you want to do. And for the treatment, just give ACE inhibitors in the patients with microalbuminuria meaning 30 to 300. Give ACE inhibitors. Excuse me. Okay. Now these Kimball-Steele Wilson lesions are very important for diabetic nephropathy. So what are these? So these are hyaline acellular deposits of plasma protein. So what are these? These are the plasma proteins that get deposited into the mesangium, leading to formation of Kimball-Steele Wilson lesions. Okay. Now let's compare this thing, diabetic nephropathy, with hypertensive nephrosclerosis. So let me just draw it and write it here. Let's talk about hypertensive nephrosclerosis. That is done due to the fact that when you have chronic hypertension, chronically hypertension causes hypertensive nephrosclerosis. Okay. That it is due to the fact that you have two things now. And if you can remember your cardiovascular, you had the hyperplastic arteriolosclerosis, which was the onion skinning, and fibroid necrosis. Okay, that's the one thing. Second thing is the prolonged HTN. Again, prolonged hypertension causing. So what happens when you have prolonged hypertension? It causes compensatory renal arteriolar medial hypertrophy and fibrointimal proliferation. That's the compensation for prolonged hypertension. Second thing prolonged hypertension causes endothelial damage. When you have endothelial damage, it causes deposition of those plasma proteins into this damaged endothelium, which causes hyaline. I'm continuing this side from here. Hyaline arteriolosclerosis, which now when you deposit so much protein into the into the vessel, causing hyaline arteriolosclerosis, now you have narrowed the vessel. So narrowing vessel leads to decrease in renal blood flow. When you decrease renal blood flow, that causes glomerular ischemia. Ischemia can lead to necrosis, and that is now called glomerulosclerosis. Okay, that's with the hypertensive nephrosclerosis. On a gross exam, it will lead to renal atrophy. And how can you prevent that hypertensive sclerosis to develop into CKD, chronic kidney disease? Just treat them with anti-hypertensive drugs so they don't have hypertension and their blood goes back to normal. When the blood goes to normal, everything that is there is going to go back to normal. So one more thing, that this hypertensive nephrosclerosis, it progresses very slowly. And advanced disease occurs in which race? In African Americans, black, and with comorbidities, so which can lead to, so again, same thing, can see in blacks, which can lead to CKD in blacks. Okay, so that was the so just talked about some hypertensive nephrosclerosis. Okay, so that's pretty much all for nephrotic syndrome. Okay,